Our next speaker is Dr. Mary Doherty, and everyone, please feel free to write questions in the question and answer box and to comment and discuss in chat. The chat will be saved so Mary can see it later. Go ahead, Mary.
Thanks, Heta. Morning, everyone. I hope you're all enjoying this virtual Autscape as much as I am. Well, it's certainly very different to what we're used to. So what I'm going to talk about today is the research that I did at Autscape last year and how I've used that data to inform my contribution to the recently published Royal College of Psychiatrists report on adult autism. I hope you'll see this as an example of what Yo was talking about on Monday, using a particular position to be heard by those with power to advocate effectively for the benefit of our community. Lots of you know me, but for those who don't, I'm an Irish autistic doctor, consultant anaesthetist, and I was diagnosed 7 years ago following my son's diagnosis. My main area of advocacy is within healthcare, where I promote an autism positive, pro-neurodiversity perspective with a focus on reducing healthcare inequalities and improving healthcare outcomes. My mission is to raise awareness of neurodiversity in medicine through my work with Autistic Doctors International, and in particular, to reframe the tragedy narrative around autism, which is so pervasive in healthcare. Research conducted at Autscape 2018 around access to primary healthcare is currently in peer review, and we hope to have that published soon. So I'll briefly touch on the main messages from that study, but my main topic today is my work around mental health and psychiatry. This talk comes with a huge trigger warning. There is some good news and some advice on how we can spread that good news, but there is some significant not so good news too. So if you're feeling particularly vulnerable today, especially if you're home alone, maybe consider giving this one a miss and just hang out in Discord instead. And also parents, this is probably not a good talk for our younger members. I'm going to be talking about the initial results from my survey last year. So this isn't disembodied anonymous data. Well, I mean, it is anonymous. Nobody can be identified personally, but it's us. It's our community, our mental health. So please, let's support each other as we look at this. There is a channel on Discord specifically for support, separate to the presentation discussion channel, and I'd urge you to use that. First of all, a quick reminder of the GP study. Some of you will have heard my talk on this last year, but for those who haven't, we know that autism is associated with reduced life expectancy and poor physical and mental health. So at Autscape 2018, I conducted a survey asking, what do you wish your GP knew about autism? 78% reported difficulty accessing a GP when required. 72% report not knowing when symptoms mean a GP visit is needed. Difficulty using the telephone to make an appointment was the single biggest barrier to access, noted by 60%. And indeed, 78% of the autistic group said that they avoided the use of the telephone in general, and I certainly do. Not feeling understood and communication difficulties were also significant issues. Higher rate of adverse health outcomes was reported, untreated physical and mental health conditions, not attending for specialist referral or screening programs, more extensive treatment or surgery due to late presentations, and 1 in 3 reported potentially life-threatening conditions which remained untreated. The main things that we need are online or text-based appointment booking, a facility to email in advance the reason for consultation, because so many of us reported leaving without discussing the reason the appointment was made in the first place, usually because of anxiety, sensory overload, or being distracted by open questions. We also appreciate the first or last clinic appointments and particularly a quiet place to wait. My main conclusions are here, and keep in mind the phrase I've highlighted as we move on. Reduction of healthcare inequalities for autistic people requires that healthcare providers understand autistic culture and communication needs. There's a link to the abstract and the poster, which was published by INSAR this year, and the preprint is available, but hopefully the peer-reviewed article will be available soon. Moving on to mental health. These are 2 slides I use when talking to professionals about autism and mental health, particularly in relation to autistic doctors, many of whom are undiagnosed. And lots of us leave the profession because we're unable to cope, and because the cost of training us is so high, and the current staffing difficulties, highlighting this fact is a good way of getting interest from our colleagues. This leads to an awareness of mental health in our community more generally, where I highlight the extent of the mental health issues, because up to 80% of us have additional mental health problems, which contributes to our excess mortality. This suicide data is from work by researcher Sarah Cassidy, and keep the figures in mind as we look at the Autscape survey data. Published figures are that 2/3 of us have considered suicide, with 1/3 having attempted it. 15% of those hospitalized after a suicide attempt were autistic in Sarah Cassidy's data, and the 11% of completed suicides, that refers to preliminary data also by Sarah Cassidy, looking at psychological autopsies after a consecutive series of suicides reported to the coroner. These are the common mental health issues that we tend to present with. But looking at our mental health, lots of you will remember this survey from last year. And I want to say thank you to the 101 of you who completed it. And also to those of you who wanted to or started to, but found it too distressing. This isn't easy to remember or to share or to talk about. So I want you to know how much I appreciate the trust you have shown by sharing your experiences. 18% were attending a psychiatrist as of last year, with 61% having attended in the past. 43% described difficulty attending. The gender breakdown is 30 male, 39 female, and 23 identifying as non-binary. Before I move on to other results, one of the issues with publishing this data is to define the population so readers know how generalizable the data is. What I propose to write is, Autscape is a conference organized by and for autistic people. Attended by autistic people with low to moderate support needs, with and without carers. The inclusion criteria for the studies are the ability to fill out an online or paper questionnaire, either alone or with assistance. And most importantly, if you have completed either of my surveys and feel this description is inaccurate or doesn't include you, please let me know. This project is moving more slowly than I had hoped, mostly because it's really painful. I've cried many tears while working on this, and I'm determined to do what I can to address all of the various factors which lead to a situation where we are so marginalized and so misunderstood that 86% of us have felt that life is not worth living. I would count myself amongst that group. This is us, our community. Participants at Autscape last year, many of you here now. 47% of you who replied have attempted suicide at some point. As shocking as that figure is, I want to remind you that you're not alone. We are a community. We share those experiences, and while we cannot provide professional support, there is the specific Discord channel set up for support for anyone triggered by this. Please reach out here or to support organizations, to your GP, your local mental health teams. 65% have engaged in self-harm, which is not something which is widely known in medical or even mental health fields. And for 21%, it required medical attention such as stitches. 27% have been psychiatric inpatients. 11% had been detained under mental health legislation, with 10% experiencing restraint. 28% of us use alcohol to manage our mental health issues, with 11% using illicit drugs. That's the preliminary data I have at the moment, and the qualitative data analysis is in progress. But early trends point to issues around access difficulties, lack of understanding, misdiagnosis, burnout, and also issues around medication. The table is from the earlier GP work, showing that 2/3 of us have had mental health conditions remain untreated because of access difficulties. So what do? We need to raise awareness of medical issues within our own community. Remember that over 70% of us are unsure of when to go to the doctor, how to describe our symptoms, and we experience challenges communicating with healthcare staff. We need increased awareness of our issues within healthcare, and I'm involved in several healthcare projects, which I'm hoping will accelerate once our research is published. Another way of raising awareness is talking and writing about the issues relating to autistic healthcare staff. Because if we can normalize the idea of neurodiversity in the healthcare community, that will eventually counteract the othering of autistic patients and challenge that tragedy narrative. As you mentioned on Monday, advocacy is more effective when you figure out the motivations of the target audience. And for doctors, talking about autism in the context of ourselves and our colleagues is novel, whereas condition lobbyists or patient interest groups are constantly competing for our attention. And the doctors group is growing rapidly. This time last year, we had about 30 members. We now have over 150, with more in an associated med students group. There's always great interest when I show the makeup of our group and the breakdown of specialties in particular. And challenging colleagues to consider if they're one of us is always interesting. And as a doctor, it's always that, it's that bit easier for me to get listened to by other doctors than it is for lay people. My approach is to use that leverage for our cause. Change happens slowly, but we are definitely making progress. And ultimately, I'd like to have a network of autistic doctors and autism aware GP surgeries and hospital departments throughout the country. I talk about stigma, unconscious bias, institutionalized ableism in healthcare, and then discuss the double empathy problem, recognizing that it's important to be respectful and start from where we are. I do the same with researchers, but also encourage them specifically to write respectfully and collaboratively. And my overall message is to resist that tragedy narrative and to be an ally. So we come to the Royal College of Psychiatrists' recent report on adult autism. It's an update from the previous version published in 2014. And while it's not perfect, it is an enormous leap forward towards depathologizing autism. I'm going to skip through most of it, just looking at some of the highlights, but the main points are on the slides, which will be available, and the full report is available online from the Royal College of Psychiatrists website. It was a long process, multiple versions with constantly updated changes, which were often inconsistent and even contradictory at times. But eventually we reached a final draft we could all live with. Now the title is...
3 minutes.
Okay, thank you. The title is unfortunate, but overall I'm delighted with the outcome because it clearly and unequivocally separates autism from mental illness. We shouldn't have to be celebrating that, but actually it's such a huge step forward that we actually do. The executive summary and recommendations are all most people will actually read unless they have a special interest. So they were important to get right. But the remit of the report was adults without intellectual disability, and it's part of the college's wider program to improve mental health services. At this point, I should say, while services are generally really poor, we have some real allies in the field of psychiatry who are working to improve them. And I think this document will further that cause. It notes the high proportion of autistic people amongst mental health service users and makes the point that diagnosis is often missed. It's overshadowed by other conditions. And getting misdiagnosis, particularly borderline personality disorder, mentioned in the executive summary, I think was a real coup. And also, when it lists all the co-occurring conditions, having burnout mentioned at this point was a real success for us, because at the point when this was finalized, Dora Raymaker's recent paper on burnout hadn't even been published. Look at the recommendations. The very first recommendation is that all psychiatrists should continue to improve their experience in autism, particularly through, their training in autism, All psychiatrists should continue to improve their expertise in autism through training and experience, and particularly by familiarity with the autistic world. Now, I wasn't sure we'd get away with that one, but there it is. That is recommendation number 1 from the College of Psychiatrists to all of their members. There is a recognition of the need for diagnostic consistency and also in relation to participatory research. Language is so important. Autism is used throughout the report to include all conditions on the spectrum, and identity-first language is used, and that's stated to be current practice. So this is now the source to quote when we're dealing with those who insist on person-first language. It recognizes that most of us are adult, most do not have an intellectual disability, and most are likely to be undiagnosed. And also says that it's common for clinicians to use autism as a justification for denying someone treatment. We know all this, but until recently, the psychiatrists didn't. And this document is to help psychiatrists recognize autism, clearly distinguishing it from co-occurring disorder. And also makes the point that the diagnostic process omits all the associated characteristics, strengths, and skills that we have. I'll skip through a lot of this just because of time, but the slides will be available. It talks about autism as a disorder, as a disability, and as a part of the range of neurodiversity. And it clearly says it's better expressed by the term condition than disorder. This is huge. This is the Royal College of Psychiatrists listening to us. I'll skip through a lot of this. They will be on the slides. Just to say that the accepted co-occurrence for ADHD, the rate is 30 to 45%. I've left out all the references for this, but they're all in the report. I've left them out just for clarity. It talks about gender, and it says that gender identity issues should not hinder access, or sorry, autism should not hinder access to a gender identity service, although it does recognize there is an association. Again, I'm going to skip through most of this. It is asking all service providers to consider how they will meet our needs and from where they will get specialist reports. Again, I'll state, we've known this for years, but to see this information in a publication from the College of Psychiatrists really is groundbreaking. I'm going to skip through this, but they are in the slides. It talks about anxiety, a wide range of anxiety disorders, which are not an intrinsic part of autism and must be treated in their own right. I love this. After diagnosis, lots of us are reassured to learn that although we are different, we're not disturbed. Again, this is the Royal College of Psychiatrists telling us we are different, but not disturbed. What a turnaround that is. Again, I'm going to skip through this. Again, cannot assume most people will be diagnosed by children's services. And that's how the process of diagnosis section starts. It challenges that assumption that most people are picked up in childhood. And asks for a developmental perspective and taking the history. And there's quite an extensive section on the interview adaptation and accommodations that we need. There's a section on the legal aspects of psychiatry, which emphasizes that most of us respect order, are keen to avoid trouble and do not offend. It says that we're generally law-abiding and even rule-bound. Here's again, clearly separating autism from co-occurring mental illness. Psychiatric input is largely about the treatment of the co-occurrent disorders that frequently accompany autism. There's no place for the routine use of medication, but that our response to medication may be unusual or unpredictable. It talks about trauma-informed care, the specialist autism teams, local provision, and out-of-area placements. There's quite a bit on that. And again, autism itself neither requires psychiatric treatment nor warrants admission, but treatment may be needed for co-occurring disorder. And then there's a description of autism-friendly psychiatric units, or what the specialist unit should be like. So one of the issues psychiatrists struggle with is this: they're doctors, they're trained to treat illness, and the idea that autism is not an illness, well, it takes a bit of a mind shift. For example, I know some who would prefer to diagnose borderline personality disorder on the basis that, well, you can't do anything for autism, whereas for BPD, you can send somebody for DBT. We know that makes no sense. So it's a task to have people understand that an accurate autism diagnosis is a life-changing gift. We know this, but it's just taken the psychiatry field a while to catch up. Here's what I usually conclude with when I talk to them, to try and convince them the benefit of diagnosis, because for many of us, it is the chance to reframe a lifetime of self-loathing and social failure. Talking about the knowledge gap is important, challenging the assumption that they already know all they need to know about autism. So I remind them to add autism to the list of potential conditions. I'll always finish with a focus on our autistic strengths. I was really impressed by the willingness of the working group, the experts on autism, to listen to our perspective and to take on board most of our suggestions. My hope is that eventually tragedy will no longer be the dominant narrative around autism, and our value to society will be recognised and celebrated. At the same time, there's nothing to be gained by not addressing the serious issues, the serious distress and the trauma experienced by our community members. And again, I want to remind you to use the support channel on Discord or other mental health supports as appropriate. I know the current services available at the moment are woefully inadequate across the UK, completely non-existent in Ireland and elsewhere. But I hope you'll agree that this work, which has originated here in our community, will go on to at least some way towards providing understanding of our needs and the provision of mental health services.